All right, I see it's 1 o'clock. We can go ahead and get started. I am showing just a reminder on some Zoom etiquette if you need it. But let's go ahead. Welcome to Beyond Buzzwords, what every healthcare leader should ask AI vendors. Thank you for being here. First up, I have our disclaimer. California Telehealth Resource Center does not provide legal advice. All materials are strictly for informational and educational purposes only. CTRC has no relevant financial interest arrangement or affiliation with any organization related to commercial products or services discussed in this session. CTRC is financially supported by HRSA and the California State of Rural Health, and our grant information can be seen at the bottom of this screen. So our agenda for today, we will start by welcoming our attendees and introductions. We'll review AI and healthcare today. We will review considerations before adoption and also some clinical considerations. We have some time set aside for questions and answers. We'll ask all of our attendees to complete a survey, and then we will wrap up for the day. So let's meet our presenters, starting with myself. I'm Amelia Ochoa Ruiz. I'm the manager for the California Telehealth Resource Center, where we lead statewide efforts to expand access to digital health. With more than 18 years of experience in healthcare, including leadership in informatics, interoperability, and telehealth innovation, I bring digital expertise and a deep commitment to improving patient and provider experiences. We have the esteemed Dr. Hickman, who is board certified in pediatrics and clinical informatics. She currently holds dual appointments at Ochin as a medical informaticist and at Randall Children's Hospital as a pediatric hospitalist. Dr. Hickman received her MD from the University of Vermont and her MS in clinical informatics from Oregon Health Science University. Her interests include improving provider efficiency, reducing note bloat, and supporting physician wellness. Dr. Hickman's current work focuses on leading clinical AI initiatives and leveraging data to understand provider EHR tool usage, patient population served, and opportunities for system optimization. Our esteemed Dr. Michael Lieberman is a physician informaticist who has worked in the field of electronic health records, decision support, and performance measurement using electronic health data for over 15 years. He has held informatics leadership roles for both EHR vendors and healthcare provider organizations. Clinical quality measurements using EHR data has been an area of focus throughout his career. He currently also teaches courses on healthcare quality and databases in the informatics program at OHSU. And he is a practicing general internist and board certified in clinical informatics. Again, welcome to today's session. We will go ahead and get started. Over the last few years, we've all felt the ground shift. AI has gone from a distant concept in healthcare to an everyday conversation. And honestly, sometimes it's an overwhelming one. It's showing up in boardrooms, strategic plans, budget requests, and of course, our inboxes. As leaders, we're expected not only to keep up, but also to make smart decisions that protect our patients and our data, our teams, and our organizations. Today's discussion is really about cutting through all that noise. So let's start with the big picture. Healthcare AI has exploded. Analysts estimate that the global healthcare AI market will grow roughly from 39 billion today to over 505 billion by 2032. Every week, a new tool or platform promises to transform clinical documentation, population health management, revenue cycle operations, you name it. And as this space grows rapidly, the difference between what's real and what's noise can be hard to see. This is why this discussion matters, because while AI holds tremendous potential, it's not magic. Leadership requires us to ask grounded, practical questions that protect patient safety, financial sustainability, access, and trust. And that's how we move beyond buzzwords and into meaningful adoption. Across California and across the country, we're seeing exciting, meaningful applications of AI, especially in spaces where resources are stretched. Rural clinicians are some of the most overextended professionals in our system. AI is already helping by automating time-consuming documentation, supporting triage and care navigation, expanding specialty expertise through AI-supported decision tools, and helping small facilities better manage limited staffing. AI won't replace humans. It augments teams who are already doing incredible work with limited resources. And in the chronic disease prevention and management field, if you look at our highest cost, highest burden conditions, type 2 diabetes, heart disease, COPD, and kidney disease, AI is showing real value in early detection, predictive outreach, remote patient monitoring insights, and support for social determinants tracking. These are areas where AI just doesn't save time, it helps people live healthier lives. So today we want to start with something practical. Questions that help you translate a vendor's bold claims into actual operational reality. You'll hear from our leaders who work day to day with AI tools from a clinical, operational, and implementation perspective. They're going to break down what to look for, what to avoid, and how to protect your organization while still embracing very necessary innovation. I'm going to now hand it over to Dr. Hickman, who's going to discuss general considerations before adoption.
Thanks so much, Amelia. So we're just going to start just with a broad over generalization of where you might find healthcare AI applications. That includes operational and administrative applications. So we're seeing a lot more applications looking to really kind of bridge the gap between the patient and the physician. So this can be automating kind of the calls that are coming to your centers, so having them be kind of the triage for patient calls. Also, in population health modules, we're seeing stuff. So we have predictive AI models that we're seeing around predicting sepsis or even the likelihood of a patient coming to their appointment. From a research standpoint, there's a lot being done of using AI for drug delivery, discovery. Specifically, how can AI be used to kind of get from kind of a product to a medication sooner? And then lastly, from a clinical standpoint, we're seeing a lot of tools. Most folks are probably aware of the AI ambient vendors. So that might be DAX and Abridge, but there's also other vendors as well. And they're looking to support clinicians using their voice for documentation. So again, this is a huge space. There's a lot of tools that I mentioned, and there are several more that are on the horizon. Next slide. So how can you navigate AI with confidence? The California CTRC has many different resources available. That includes a vendor checklist. There is a healthcare AI foundational document. There's also a guide for governance, and then there is a unintended impact. So we encourage you to go to caltrack.org, which is in the lower left-hand corner, to explore these tools. So when thinking about the kind of a CTRC vendor checklist, there are a lot of things that should be considered. We're going to be speaking about both of these today. I'm going to take the broader considerations, and then I'll hand it over to Mike to talk about the nutrition label. But just very high level, broad considerations really include, looking at this vendor as this is a new relationship, a new partnership that could be lifelong, and you have to protect yourself, but also protect your patients. So just looking at things such as like, who is responsible for the data? What is their training and support going to be like? What is the cost? What is the lifetime cost of ownership? These are all things to consider when speaking to a vendor. And then also who's liable. So if a mistake is made, is that liability on the vendor or the provider? Um, so definitely a lot to consider, and I will walk through those next. So we'll transition. So I just want to say not all AI is created equal. I saw this image on the web and I think it really sums up to what people are experiencing. You have a number of different vendors in one space, and you might, when you get to talking to them, you realize that while they're offering the same technology, there's also some subtle differences between them that some could be red flags and some could be green flags. And so hopefully when we finish this presentation today, you'll have a sense of what you should be asking for and looking for in regards to identifying those flags. Next slide. So some data just to get started. So 95% of generative AI pilots are failing to produce meaningful results. And so this again highlights why it's important to pick a vendor, pick a really good vendor. Second is 42% of companies that reported scrapping AI initiatives in the last year. Moving over to the right-hand side, 60% is the prediction of the number of AI products that will be abandoned in 2026. And then there is an average of 4.3 pilots led per organization. So again, there's a lot of, opportunity here in looking at this data to say, how can we make this better? And I think it starts with the vetting process. So we'll go through that next. So first, when you're thinking about, laying out or bringing AI into your organization, it's important to start with a problem. We're seeing oftentimes that folks are seeing AI and they're like, we want this AI tool, let's put it into our system. But they're not really solving a problem. So when you're kind of exploring AI, I think it's important to really evaluate your system and figure out what is being used, what AI might already be integrated. Because chances are you already have like a tool that has maybe an AI functionality on it, or people are using AI, in another avenue off your EHR. So it's important really to kind of define that problem. And then once you define the problem, being able to prioritize. So you want to make sure that kind of you're hitting either the things that matter most to staff first or the things that would give you the biggest win first. Because some of this is really going to be changing the mentality of your workers to show them that, this is going to be a benefit for them. And then lastly, after you've identified the problem, you want to kind of like create a decision matrix. This is the best way to eliminate decision biases, and trying to figure out like how you should prioritize these problems. So again, we'll move to the next slide, but make sure that you have a problem in mind when you get started. Next is really looking at organizational needs. So the best way to do this is really to have a multidisciplinary team. Again, you want them to help evaluate your system as well. On this team I think it's really important to have clinicians, really like in a lot of disciplines, because you might find that, one tool might be better than another because it affects multiple different disciplines. Also like data sciences, IT, you might even have some ethicists if you have that as well. And then next, oh, sorry, I believe it's the same slide, so we'll just keep moving. Next, once you've done that, we encourage you to have some sort of vendor selection criteria. So this could be used to evaluate the vendors. And uh, we, the CTRC has some vendor selection criteria, but this is important because at the end, you want to be able to say, this was the ranking system we used, or because these providers responded, or these vendors responded this way on these questions that we deem were high risk, then, maybe we're going to give them a higher number and they're going to triage a lot lower. After you have that vendor selection criteria, it's important to really research potential vendors and also their competitors. So you really want to like get out there and say, this is one ambient vendor, but what do the other ones do? How do they relate to this product to make sure you're not just kind of geared towards one and not able to see the full landscape. After that, we encourage you to request and evaluate vendor proposals. So again, this is another way to eliminate decision bias and then start conducting vendor interviews and demos. For those demos, it's important to really get stakeholders there, to really understand, how things will be operating on many different facets, whether it's IT or clinical. Next slide. And then we talked about the questions. As you start to dive through the questions, these are some categories that you might consider asking different vendors. So just to call some of them out from an ethical standpoint, you might want to understand like what is the demographics of the training data and was or how was it evaluated for biased. From like a governance standpoint, you might be curious about security measures in place to protect patient data, and also how they're ensuring that it complies with like HIPAA and the California privacy laws. Uh, for kind of cost and sustainability, I mentioned this before, but the total cost of ownership is important. You definitely don't want to sign up for something and then realize, the subscription rate is a lot higher than expected and maybe have to pull out of a good tool because we found that it's harder to, get rid of a project than, implement one. And then lastly, one I'll call out is around um, just kind of getting at this like customer service support, technical support. It's just getting an idea of like, where has this tool been tested and audited, and are there other organizations you can reach out to kind of get some information about how their process went. So you really want to treat this as a new relationship where you're, trying to just talk to everybody to get a full picture of what this vendor relationship will be like. Next slide. Next, okay, thanks. So once you have those questions, again, you'll conduct the pilot, and then it's time for final selection and contract negotiation. And again, remember, when you're making this decision, things you want to consider is your prioritization matrix, how the demos went, kind of the interviews, your evaluation. You might even consider doing a pilot. Sometimes if the vendor will allow for a pilot, it's a great way to get an idea of what this product will perform like in your organization's EHR, and also kind of how it's received by clinical staff, etc. Once you've made that final selection, the implementation, I think this is huge, is one bullet here, but change management is a huge part of this. So that includes incorporation into workflows. So again, we don't just want to adopt AI tools, we want to adopt the tools into workflows. Upskilling workers is important. So just thinking about how you might do that, whether it's giving people clinic time off to do so, or having different kind of bite-sized videos, and also creating kind of in-user tools and resources so that they can be able to upskill on their own is important. And then finally, once things are up and implemented, it's important to really monitor these vendor solutions. So AI can drift. And so, for example, it might be telling you today that the apple is uh, pure red, but tomorrow it might shift a little bit and say the apple is a little red. And so you want to be able to know when that drift is happening and be able to kind of get in front of it so that you can ensure that the product you purchased and the outcomes you were getting initially are still happening 3 to 6 months later. So I will shift to the next slide. So in conclusion, it's important that you assemble the right team. So, make sure you have the right people at the table for these conversations. Make sure that you focus on the goal. I think it's easy to, get excited about the new and shiny, but making sure that you have a problem that you're actually tailoring your AI search for. Two, to focus on the best fit. So again, evaluating vendor strength, their uh, return on investment, and also integration. And then lastly, don't overlook the red flags. So whether that's overpromised claims. We're finding there's a lot of AI startups in the space right now, many that don't have good data governance structures. So it's important to really look at those and be mindful and say, we don't want to take this risk and use that as kind of the out versus we'll give them a shot because at the end of the day, it's patient data that's at risk. So now I'm going to turn it over to Dr. Lieberman, who's going to talk about specific clinical considerations and tell you more about the model card.
Thank you, Dr. Hickman. I will be talking about specifically evaluating AI applications from a clinical standpoint. Much of that useful clinical information has been incorporated into a model facts label, which is similar to a nutrition label for food. And so here is a nutrition label. Why do we have nutrition labels? Well, I think it stemmed from the need to have additional information about what's inside a package. So you can see a nicely packaged frozen lasagna, but you're not really sure what you're getting from just looking at it. And the nutrition facts label gives you key information. So in a simple format that's reproducible and that you know kind of where to look for that information. So in this example, we're seeing that, first of all, there's a serving size. You're going to have information about calories, but if there's actually 4 servings per container, then it means it has 4 times that amount of calories. So that's key information. And then where are those calories coming from? There's, fat, carbohydrates, protein, and so you get that additional information, and then some additional information about what sort of nutrients are in the food that you're purchasing. So again, standard information. People learn how to read a label so that you can find the information you need quickly to understand what's inside, and that can drive your decision as to whether or not you're going to purchase that food. So there are a couple of two organizations that are national multi-stakeholder organizations that have sprung up to facilitate the use of AI in healthcare. One of these, the Health AI Partnership, describes themselves as a multi-stakeholder collaborative empowering healthcare organizations to use AI safely, effectively, and equitably through community-informed, up-to-date standards. Both of these organizations have sponsored model fact labels. We've chosen to focus on the Health AI Partnership version as they have made theirs available for use without charge through a Creative Commons license. They've also updated their model to comply with federal health IT rules. And this is an example of what the label looks like. This is the nutritional label for AI models in healthcare. Um, this is an example of risk communication that the U.S. Food and Drug Administration defines as a term of art used for situations where people need good information to make sound choices. So again, that's the idea behind this. It serves the audience of clinical end users at the implementation stage and is distributed via channels that are closely integrated with clinical decision support. So it has basic information. It starts out with basic information and things, and we'll just kind of walk through what information is on the label. So you start with the model name. In this example, it's deep sepsis. The locale is the Duke University Hospital. When it was initially approved and when it was last updated, what version it is, who developed it, and developer contact information. And then it has the summary, which is a quick description of what it's meant for. So this is an EHR. This model uses EHR input data about the patient's current inpatient encounter to estimate the possibility that that patient will meet sepsis criteria within the next 4 hours. It talks about when it was developed and where it was developed, and that it was licensed to a third-party, Cohere Med, in July of 2019. And then we get into discrete fields around it. So the mechanism, the outcome again is looking at specifically at sepsis within the next 4 hours. The output is a percent chance of developing sepsis within the next 4 hours. The target population is adults presenting to the emergency department, and it's predicting it every hour. The input data source in this case is only electronic health record data. And the data type, it has demographics, lab values, vitals, medications administered, sensitive data, sensitive attributes include age, gender, and race. The training data was obtained at the Duke University Hospital at that time period, and the model type is a recurrent neural network. Go to the next slide. And then validation and performance data. So they're giving us a good information around AUC, which is area under the curve. For risk models, it's a useful statistics that basically looks at the performance of the model at different levels of sensitivity. So if you're going to say this is giving a percent chance of developing sepsis from 0 to 100%. And so when you're implementing the model, you have to decide kind of what a cutoff you're going to use for some sort of intervention. If you use a very high cutoff, you'll have high specificity, so you will be finding it won't fire very often, but when it does fire, you'll be very likely to be positive. If you use a very low cutoff, you'll be less likely to miss somebody that would develop sepsis, but you'll be firing for a lot of patients that don't have it. So area under the curve tries to give you kind of a broad overview of how well that model is performing. And in this case, the area under the curve is actually quite good. So 0.88 for the local retrospective cohort. Anything above 0.8 is very good. Oftentimes we will use models kind of in the point above 0.7, but in general, that's performing well. And so in this, they're saying that training cohort, they don't give any information because that's the information, that's the set that was used to train it. And then after they've trained it, they do a local retrospective running of the data. And that's first what you're looking at. So in that cohort, it's 18.9% prevalence. So that means 19% of the patients in that training set did develop um, sepsis, which seems fairly high to me. But the area under the curve is good. But even with a very good area under the curve, you can see that the positive predictive value at a sensitivity of 60%. So if you set that threshold so that you're uncovering the 60% of the patients that present are getting a positive result, only the positive predictive value is only 14%. So it still means there's going to be, a lot of false positives there. Another way of looking at it is if you have a positive predictive value of 50%, the sensitivity is point, or positive predictive value of 20%, the sensitivity is only 0.5. So you'll still be missing a lot of patients that have sepsis. So again, it really is going to be up to whoever's implementing this model to determine, what you want to set your cut point as for positive. But it does give you an idea of how well the model is performing. And then, oh, sorry, go back, not quite ready. So then the next line is local temporal. So when we have those first two, or the first one is about training in general, and then how the model performed, kind of where it was developed. But then you want to also know how well is this going to perform for my area, or for where I'm implementing it. So that's the local temporal one. And in this case, only 6.4% of the patients presenting actually have sepsis. And for that population, the AUC actually ended up being 0.94, which is even better. And then it has the same sensitivity, PPV at sensitivity of 60%, sensitivity of positive predictive value of 20%. So again, that's a key part of this, is kind of like assessing how well it performs in your population. The next part of this has risk mitigations to ensure fairness. It talks about, what the issues might be here, and how the demographics of your local group may vary because of differences that you have there. And now let's go ahead to the next slide. And then this part here is really important. The uses and directions gives additional information about how you should actually use this model. And the first part, I think is really important. Intervention prompted by the model output, and really most of these kind of hark back to this. So the idea is that what the model is going to do is give you a number, and you will set a threshold for when you want to use an intervention for that. So when it meets that threshold, what are you going to do with that? And in this case, the idea was that that somebody would look at that output, and the nurse would communicate to the attending that they had basically a signal, a positive result for this model, which would result in chart review and bedside assessment to independently to evaluate whether there's a significant sepsis concern. And the benefit here, of course, is that you're better able to identify, or you're more likely to identify, a patient that is going to go on and develop sepsis, so that you can intervene early and improve patient morbidity and mortality. The target population and use case is that same. It's people presenting to the emergency room, and whether there's going to be a rapid response team nurse that is going to review every high-risk patient with a physician in the ED to confirm whether or not to initiate a sepsis protocol. Again, intended user of the model are the nurses and the physicians. The general use, again, it's clinicians, nurses and clinicians in the ED. The appropriate decision support. Basically, this is just saying that the goal here is to identify patients who are at higher risk for sepsis. It's not, it is, it still is up to the clinicians to determine whether you think the patient is appropriate for additional sepsis intervention. And then before using this model, it does say to do exactly what I mentioned, test the model retrospectively and prospectively. So you can implement the model, you can turn it on, you can look to see what sort of how it performed on a retrospective cohort within your data. And then you can also leave it on for a month or 2 months or 3 months or something and see how it performs prospectively and how many patients would be flagged for that, for sepsis, and whether or not they actually went on to develop sepsis. So that's an important step as well. Um, and then safety and efficacy evaluation is interesting too, because uh, what they know is that the model does actually identify patients that are more likely to develop sepsis, and we know that implementing a sepsis bundle can improve an outcome from sepsis. What we haven't shown yet is, does using this model improve outcomes within this setting? But so you have, yes, it does. It improves identification of sepsis, and we know that sepsis bundle helps, but it doesn't. We haven't put all of the pieces together yet to know whether or not it improves an outcome. And I will again really stress that anytime you're going to implement a model, the intervention is really the key part to it. So what are you going to do with positive output? And what do you have everything in place? Do you have a you know a the person that's going to review that data, and do the people that are the people in place that are going to make that intervention in place, or all of the parts of that intervention in place? And then it has warnings. So it has risks. Basically, it's not perfect, so it can misdiagnose sepsis. So you are going to get that it's going to identify patients that are at high risk for sepsis that may never develop sepsis. Inappropriate settings is really important as well. So this was trained and evaluated on patients presenting to the emergency room. It's not meant for patients in the ICU. And then the clinical rationale is important too, because uh, physicians, providers, I mean, we like to understand, like, why is it firing? And it won't tell you that. It's going to, it takes a lot of variables into place and it spits out a number, but it doesn't say, well, that it's because this patient has this, this, and this, we're showing you this. Neural networks don't work that way. I mean, it's you put in a lot of information, and it generates this output that you can kind of think of as like a feeling that this patient might have it more. So you can't point to a specific thing and say this is why it's firing. And sometimes, that's problematic for providers. Another example of this, and kind of making sure that you're using it for the appropriate setting and for the appropriate use. The people that came up with this model had a paper associated with it, and they mentioned another model around predicting mortality from pneumonia. And the idea was that, well, we could use this to determine whether a patient can be treated as an outpatient or should be admitted to the hospital. So thinking that a patient at lower risk for mortality could be treated as an outpatient, a patient at higher risk should be brought into the hospital. So they developed a model, and they found that patients with asthma were actually less likely to die from pneumonia. And so if you were going just from that, you might be more likely to discharge a patient with asthma. And that wouldn't be appropriate. The reason that they had lower mortality is because they were more likely to be admitted directly to the ICU and receive a higher level of care, which prevented mortality, but it wasn't around admission. So it's just really important to think about how the model was set up, and the information that it's giving you, and how you should use that information. All right, at this point, I am going to turn it back to Amelia for a few other considerations.
Thanks so much, Dr. Lieberman. So at CTRC, two common discussions that we have are revolving around reimbursement and liability. And one of the most overlooked questions in the AI purchasing process can be the simplest. It's how will the solution be reimbursed, or will it be reimbursed at all? And healthcare leaders know that great technology means nothing if it doesn't fit into a sustainable financial model. And AI solutions may promise efficiency, but vendors often gloss over the practical realities of revenue cycle integration when appropriate. So, as you evaluate tools that claim to reduce provider burden or improve care delivery, make sure you ask a series of questions, such as: does the AI support billable services? For example, will the AI support with documentation for RPM or behavioral health codes in a way that meets CMS requirements? Or does it create encounters that meet medical necessity? Not just improved efficiency, but documentation that will stand up to an audit. Does the AI integrate into existing workflows tied to reimbursement? If your clinicians are still doing manual workarounds, you're not getting the ROI that you were promised. And what is the vendor's understanding of state-specific policies? Your vendors should be familiar with those state-specific policies and not learn them from you. We're entering a period where AI will absolutely enhance clinical care, but reimbursement will determine which tools survive and which tools will disappear in a few years, like Dr. Hickman mentioned earlier. Leaders simply can't afford to ignore these types of questions. And the second area we wanted to highlight was liability, because every healthcare leader should be crystal clear on who is responsible when something goes wrong. AI vendors often position themselves as decision support, recommendation engines, or workflow enhancers, but none of these labels answers a core question. If a clinician relies on your AI and the output is wrong, who is liable? The clinician, the organization, or the vendor? When talking to vendors, be sure to ask, how is your model validated and who validated it? Was it peer reviewed, tested in clinical environments, or benchmarked against diverse populations? What guardrails are built in? Does the system notify clinicians when data is missing or confidence is low? And how do you handle incorrect recommendations? Is there a document signed risk sharing approach, or does your contract push all liability onto the clinician? And how often do you update your models? Or how do you update models and how often? If the model changes and a clinician outcome is affected, leaders need to know how the responsibility is shared. Liability is not a hypothetical concern. It's emerging as one of the most critical components of AI governance, especially for rural providers, small hospitals, and systems that may not have in-house legal or compliance teams. The bottom line is that every AI tool must fit inside a clear liability framework, because innovation doesn't replace accountability. All right, so let's see, we have a couple attendees that are asking questions in the chat. So I will ask Jocelyn to see what questions we are going to pose to our panelists.
We have one question in the chat where it says, how willing are vendors to answer these questions? This is for Aaron.
Yeah, thanks so much, Jocelyn. That's a great question. We're finding that it really is dependent on the vendors. As I mentioned, there's a lot of startup vendors in the space, and a lot of those new kind of startup vendors haven't really even explored these questions. And so oftentimes when you ask them, they're a little bit like shocked because they haven't been asked kind of detailed questions. So that's why it's really important to push them. I think as they start interacting with more and more healthcare organizations and we start having the adoption of the model tool, it will be easier for them to get to the endpoint. But right now we're noticing that we almost have to like push them for information. But for more of our established vendors, that have been asked these questions from other organizations, oftentimes they're able to provide it, or they're even willing to create a model card for us and share that as we're asking questions. So I think, hopefully one day the goal will be for all the vendors to openly share, but as we know, kind of with everything, there's some safety in not sharing for them. So I encourage you to push and get everything you need.
Thanks, Aaron. We have a question for Amelia. What kind of liability do providers face?
Yeah, that's a really great question. I think it depends on the contract and how that's written up and the vendor that you're working with. There are many vendors out there that really do put the onus on the clinician as far as liability goes. So it's really important for the clinicians who are utilizing these tools to understand the models, understand how outputs are derived, understand what their liability onus is for relying on that data, and asking those appropriate questions that was presented earlier to really ensure that liability is understood upfront.
Thank you. This is similar to the liability, but if there's anything else you can add, what steps should we take before integrating AI into clinical workflows?
Yep.
Dr. Hickman, do you want to take a shot at answering that question?
Sure. So the question was, what steps should you take? I think it's really one thing that we always do, like as we're thinking about this is like one, we want to have like really good communication with the vendor, so we keep the vendor engaged throughout the entire process. Oftentimes, like, we'll do a kickoff call with them. We'll see whether it's a good fit. So as you're looking at vendors, make sure it's a good fit. Keep them involved throughout the process. Like, I think it's like not great to engage them early and then at the end you're like, this didn't work and they have no visibility into the process. As I mentioned, like really doing pilots and engaging your staff to get on board, having that champion who's going to speak towards AI. And also with that, like I think it's important to find people who aren't excited about AI because often they're the ones that kind of change the landscape for other people of like, you're like Dr. Jones, maybe who he refuses to use an iPhone. He has a flip phone, but if you're able to convince Dr. Jones that like AI is changing his life and he's able to kind of speak to other people, that really hypes people up because they're like, oh, well, like he doesn't even like technology and he's like doing this adoption. So I really think it's like a play of like engaging the vendor, finding those champions, like again, the ones that are gonna be kind of the super users, but also the ones on the other end of the spectrum and also like continuing to educate staff about updates because sometimes, the product changes and maybe, it didn't work for me in version 1, but now we're on version 6 because the team is making iterations. It's important for the like clinical staff and the users to have that visibility so they can go back and test those workflows because maybe, that will increase adoption.
That's great. I think it's very important to find your champions and just make sure everything is transparent and having folks involved. Thank you. We have other questions here. Where in radiology are we currently seeing the most AI adoption?
I recently went to a conference and a lot of one of the big things they were speaking in terms of radiology is they're expecting this huge kind of gap in radiologists in 2035 or something. And one of the kind of the biggest plays that they were making is like using AI as kind of a triaging system. And so, there was an organization there that was saying, we AI is not replacing the radiologist, but we basically are able to use it as the first line triage, as you might a resident, for example. And from there, they're able to read kind of the what AI is flagging as the high risk or the strokes, etc., and then go back and read the other ones. And so they've like been working with this model for it sounds like for at least a year. And so they have the confidence now. It's like, we can kind of release this preliminary AI read to the clinicians. They can like take a look at it while we're getting to it, and everybody knows it's read by AI. But it's really speeded up kind of their processes. So I think that's kind of the biggest play right now for radiology.
Great, thank you. We do have a few other questions. How can employees evaluate whether an AI tool genuinely supports the learning and interpretation skills rather than creating over-reliance?
I mean, I think that's a difficult one. I mean, I do think any, anytime in medicine there's that issue, and I'm thinking, even with that last question around like ECG interpretation, we've had now kind of automated ECG interpretation for decades the where the machine will spit out something about what you're seeing, and it is useful. I mean, especially when it says things are normal, it's highly likely that they're normal. But I always have, a lot more questions when it finds abnormalities. I know when it like finds prior evidence of an MI or whatnot, you have to look more closely to see, why is it saying that and is that really true? And I think that AI would be, I mean, that is probably an example of AI as well, but it's that sort of thing where you can use it to, you shouldn't accept it at face value, basically. You still need to kind of look at the source data and the patient in this case and decide whether or not you think what AI is giving you is really accurate or not. So it's one piece of information, but it's not, it's not definitive. Um, and I think, and so that really gets down to kind of training and just, how are you going to use these tools?
Great, thank you. I think we have time for one last question, if that's okay with everyone. Yeah. The last question is regarding patients. Any feedback as far as the need of patient consent to let AI handle patient data? What to do if patients opt out?
Yeah, I think that's a great question. I mean, I think the easiest path right now is through like the ambient vendors where you're kind of activating it for each patient. So we like depending on what state you're in, I know, this is California geared, so you have to get consent from the patient to start the ambient recordings. So from that lens, I think it's easy if they opt out, you just wouldn't use you wouldn't engage the ambient vendor with them, and you instead might choose to go outside the room and just kind of document on the patient either through typing or you might just use the ambient vendor like a scribe almost without interacting with the patient. I think where it gets harder is when you start to embed AI tools into the EHR. And so, for example, you might have a tool that's doing a chart summary, and how do you, if a patient is like, I don't want AI used in my chart, how do you navigate that? I don't think anybody's like really figured that out yet, truthfully. That's, we've had some early discussions with Epic, and I know I've been seeing some literature online. And I think that's probably going to be kind of the next thing is like working with the vendors to have some sort of solution of like, this chart, because the patient doesn't want any AI, nothing AI will be run through it. But on the flip side, I think, it we actually may never get there because AI is gonna at some point we're gonna be looking at a visit and saying, if the provider didn't use AI, maybe they were negligent, um, or weren't doing service for the patient because if something is missed in that chart and they didn't use AI, you might say, well, because you didn't use AI, it was missed. And so, unfortunately or unfortunately, I think AI is kind of seen as this canonical decision tool slash like almost like an up-to-date or open evidence, where it's going to become pretty similar to using those tools. And right now, there's not really a vetting system or, a mark to say, I had no idea, but I used up-to-date to get support for this. And so I think it's going to kind of marry into that. But eventually, I think it as we talk more to vendors and we get better understanding of how to do that, that might be an option. But right now, it's all in under that umbrella of like a clinical support tool.
Awesome, thank you. We actually do have a few more questions. Um, what if, and this is for Dr. Lieberman, what if a vendor does not use a nutrition label? Should we ask them to use a nutrition label? Is that common?
Yes, I mean, I think that if they don't give you that, and I think it's perfectly reasonable to point them to it and say, yes, you would like this information for this system, and ask them to provide that for you. And I would defer to Dr. Hickman as to how often that happens.
Yeah, I would say I 100% agree with Mike. I would push them for the model cards. We've reached out to a couple of our vendors for model cards, and when I was talking to my colleague the other day, I think out of 5 vendors, she had gotten a model card for one and a half. I think one was working on one this week. So I think you just have to push them and really keep them engaged and give them the reason why. And ultimately, I think it benefits them because other people are going to be asking for it. So, maybe you're just the first one.
Thank you so much. That is it for our questions.
Thank you so much, Jocelyn. And again, for Dr. Hickman and Dr. Lieberman's contributions to answering those questions, we are now going to ask that all of our attendees take a very quick survey. I see it's popped up. I will allow for time for everyone to answer those questions, and I will move on for now. So just a reminder to please stay informed by connecting with us. We have a three-part series Spark session that will be available on LinkedIn coming up shortly. One is already available. The other two are very quickly on their way. They are short sessions regarding the calendar year 2026 Medicare physician fee schedule final rule that starts in January 2026. And we also have a YouTube channel that you can subscribe to. Some upcoming events that CTRC will be at is the 2026 Rural Health Symposium hosted by the California Hospital Association, the 2026 California Rural Health Association Conference, and the 2026 CTRC Digital Health Summit that we will be hosting. Theme this year is Bridging the Gap, Digital Health and AI for Smarter Care, Stronger Teams, and Sustainable Healthcare. As always, we look forward to engaging with our rural health leaders and sharing insights on telehealth and digital health innovation. Remember to follow us on LinkedIn if you aren't already. And thank you again to Doctors Aaron Hickman and Michael Lieberman for your contributions today. Really great information shared. Feel free for attendees to reach out if there's any additional questions. Thank you all again for your time and for joining us today.